Hi guys, welcome back to another high yield rapid pharmacology review. I am Mike and you'll hear Mina a little bit later. As always, just a little disclaimer, we're sifting through the material and taking what we think is the most important parts of it. We are not including everything, so please do read all the notes, and we're not sanctioned by CMS to give this review. We're just doing our own little thing over here. All right, Parkinson's disease. Now, for whatever reason, test makers and teachers really like to speak a lot about it. They like to really ask you a lot of the pathophysiologic questions. The that complex diagram of substantia nigra to subthalamus to basal ganglia. I'm sorry, I don't really like. That is just too beyond me. But they tend to like to ask a lot of questions about that. So we'll get into some of the drugs for Parkinson's disease. So first with a question, we'll talk about a 65-year-old Caucasian male presenting to your office with increasing muscle rigidity, gait, and instability. He was diagnosed with Parkinson's 2 years ago and has been treated with selegiline. His past medical history is otherwise insignificant. His father also suffered from Parkinson's, and his mother died of an extensive stroke. You consider switching to levodopa to control this patient's symptoms adequately and discuss the adverse effect profile of levodopa with him. Which of the following adverse effects is most likely to persist after adding carbidopa to levodopa treatment? Nausea, vomiting, tachyarrhythmia, hot flashes, postural hypotension, or anxiety and agitation. And the answer is E, anxiety and agitation. I believe nausea and vomiting is something that you eventually become tolerant to. Well, the first thing we should say is, we'll talk about levodopa, but levodopa is just an isomer of dopamine. And we're replacing the dopamine in the basal ganglia. And the issue is we have to get it from our peripheral circulation to cross the blood-brain barrier. And so when we do that, we can have dopaminergic side effects. So arrhythmias, hot flashes, and postural hypertension. Well, arrhythmias and hot flashes are both things that can occur just because of the dopamine. The nausea and vomiting is another thing that can occur because of the dopamine. Now, by adding carbidopa, we're inhibiting peripheral conversion. So we're not likely to see B or C after taking carbidopa, and then nausea and vomiting eventually we become intolerant to. Postural hypotension is more of a Parkinsonian, just something that occurs with Parkinson's. However, unfortunately, agitation and anxiety, because of the dopamine imbalances in the brain, you tend to see that a lot with patients who have been on Sinemet or carbidopa levodopa for long term. So you have to know these drugs and you have to know the pathways. So this is a chart from first aid. I'm going to just go one by one. So what inhibits the breakdown of L-dopa into dopamine in the peripheral circulation? Carbidopa, or dopa dehydroxylase inhibitor. And then there's another way to break down dopamine in the peripheral circulation, and that is by our COMT. So our COMT inhibitor is R, entacapone and tolcapone. And this is important because at the nerve terminal centrally, we only have tolcapone. So you do need to remember that entacapone is peripheral only, whereas tolcapone acts centrally and peripherally. Number 4, our MAOI inhibitor, selegiline, resiligine. Number 5, we are increasing the amount of neurotransmitter. This is going to be amantadine, our NDMA receptor antagonist that, for whatever reason, also increases dopamine in the synaptic cleft. And then finally, we're going to activate the dopamine receptors, as it is, bromocriptine, pramipexole, and ropinirole. are ergot or non-ergot dopamine agonists. So, start off with the big guns, Sinemet or carbidopa-levodopa. So as I already alluded to, levodopa is just a dopamine precursor. It is just dopamine, levodopamine. I believe it's a levo isomer. Carbidopa, very importantly, is our L-dopa peripheral metabolism inhibitor. So what we're doing here is we have a patient with Parkinson's. We are supplementing and literally giving our patient dopamine, but we're trying to inhibit the peripheral conversion because there's a lot of side effects that come with the peripheral conversion. Primarily use is obviously Parkinson's. It can treat the bradykinesia, rigidity, and tremor of Parkinson's. However, the flat affect and shuffling gait are not as effectively treated. So side effect, we've talked about this before. So dyskinesia is so it's associated with Parkinson's, but it's really associated with a patient who has been on Sinemet or carbidopa-levodopa for a number of years. So you'll see it in Parkinsonian patients, but it's sort of this. It's a neuroscience. So pretty much, after a patient's been on Sinemet, we can't really tell how long or when it starts to happen, but after a certain amount of time, the brain becomes tolerant to the effects, or something happens and your brain sort of flips a switch and you start having dyskinesias. So these are irreversible. Once you start having this side effect, even when you stop the drug, now you're exhibiting dyskinesias. So it's unfortunately an irreversible side effect of the drug. And it also becomes more prevalent as the drug levels hit their peaks and nadirs. As this starts to occur, you'll see it more so in patients who are peaking on their drug dose and when they start taking it more often and they need higher doses. You can see lots of adrenergic side effects. Obviously, levodopa is dopamine, so you can see tachycardia, arrhythmias, and hypertension. There are also behavioral side effects, psychosis, hallucinations, delusions. Again, think excess dopamine. You can see orthostasis, nausea, vomiting, diarrhea from the dopamine as well, but this is something that we do become tolerant to. And finally, not so much a side effect, but just the pattern of giving these patients drugs. So when they start off on carbidopa-levodopa, they're started off on the lowest dose. And over time, there's you have to increase the dose, and you're going to have to increase the frequency. So you'll start to have patients, and if you, a good example would be if you've watched, an interview by Michael J. Fox. There are times when he needs to, step aside. If you just YouTube something, and he will take some medication, and he'll have, the drugs will wear off, and he will start to suffer from some more bradykinesias and rigidity and tremors, and then he'll have more on after he takes his drugs, and he'll have some more dyskinesias. So it's unfortunately a balancing act, and over time, as you start taking more Sinemet, you'll see that patients are going to suffer a lot more side effects from the drug wearing off and from the drug peaking when it's in your system. Very important to know the side effects and the mechanism of Sinemet. Dopamine agonists. So when a patient is actually diagnosed with Parkinson's, you don't give them carbidopa-levodopa right away. You actually first try to just stimulate the dopamine receptors in the basal ganglia. So first generation, whenever I've said this before, when you think first generation, you want to think natural products. So ergot, I believe ergot was a plant, and they were able to derive from this plant natural dopamine agonists. So we have two. We have bromocriptine and pergolide. And of course, pergolide was withdrawn from the market because of heart valve regurgitation. But it's on your drug list, and it specifically is mentioned that it was withdrawn because of heart valve regurgitation, so that's all I would know about it. However, bromocriptine is actually quite commonly used. So this is a dopamine 2 and a dopamine 1 antagonist. And again, I'll bring this up. I talk about first generation, a good rule of thumb is that a first generation drug is a messy drug. So it's an agonist at the dopamine 2 receptor, and it's an antagonist at the dopamine 1 receptor. You'll see for our, more advanced drugs, the scientists get smarter and they're able to figure out a way to have the drug work more efficaciously by isolating the receptor that we want to work on. So just tip, generation 1 versus generation 2. There's a possibility that could be more natural product. That's always the case. And then to take it a step further is think, more generation 1, a dirtier drug. It's hitting multiple receptors, and later generations are more effective and have less side effects. But anyways, I digress. So again, this is an adjunct and also an agent that's used to start. You want to titrate slowly because the side effects can be quite bothersome. Orthostasis, arrhythmias, and hallucinations. So we're moving on to our second generation. These are the non-ergot derivatives, so non-natural product. Pramipexole and ropinirole. So these are our dopamine 2 agonists. So we're specifically activating this D2 receptor. So these are used more so than bromocriptine, as I mentioned previously. Cleaner drug, specifically activate D2. So these can be used for monotherapy for patients, and they can also help reduce the on-off effects that they experience while, using Sinemet. So just a couple of facts. Pramipexole has a longer half-life. These are all contraindicated in pregnancy, and then again, because it's a dopamine receptor, we want to worry about hallucinations, and this one doesn't really have, or I can't think of a pathophysiological reasoning, but for whatever reason, some sleepiness issues with a side effect. And then finally, impulse control, so we're activating the dopamine receptors, and there are certain drugs that patients can start taking and they'll become compulsive gamblers. It's very odd, but we think about dopamine as a neurotransmitter, and the reward system. It's not too out of the. It's not something that doesn't make. It's not something that doesn't make any sense at all. We can tie and figure out a reason why. All right. They're still dopamine agonists, but a little bit more, I guess, the oddballs. So we have amantadine. So amantadine enhances dopamine release, or it either more possibly blocks dopamine reuptake. We're not quite sure how it works. It's also a muscarinic antagonist and an NMDA receptor antagonist. So amantadine was actually originally used for the flu. It's an antiviral, but it was found that it enhances dopamine release, so it can be used in early monotherapy for patients. However, you will never see this used ever. This is sort of a textbook example, or a textbook fodder. They just want to put this in here because it's historic and we used to do this, but you don't use it anymore. It can also be used as an adjunct to reduce the motor side effects, bradykinesia and rigidity. Side effects include hallucinations, insomnia, nausea, and vomiting. The key for amantadine is, I would say, understanding the mechanism, how it can possibly reduce dopamine release or block reuptake, and understanding that it's also an NMDA receptor antagonist, because that's kind of funky and they like to test that. Apomorphine. Now, apomorphine is also a dopamine agonist, but this is a rescue drug. So if we have a patient who is having a severe off time, so they maybe forgot to take their Sinemet dose and they're experiencing severe bradykinesias or severe effects from Parkinson's, you can actually administer this drug to sort of have to bring them back. Unfortunately, this is a medication that's extremely emetogenic, so it must give them a little ondansetron or some sort of anti-nausea medication before you give them this, because it will cause them to immediately just have a lot of emesis. Fun fact, It's called apomorphine, but it is a misnomer. It is not an opioid. All right, so some more adjuncts. No, so these are sort of in the realm of carbidopa. We have a few inhibitors that are inhibiting the breakdown of dopamine. Inhibit breakdown, increase the amount available. So we're increasing the amount of dopamine without actually giving any more. So we'll talk about our MAOI inhibitor. We've talked about them before. This is selegiline. So this is an MAOI-B inhibitor, and it prevents the metabolism of dopamine. Whereas we talked about the MAOI-A inhibitors, which prevented the breakdown of serotonin. So these can be used in monotherapy and as adjuncts of carbidopa and levodopa. They do reduce wearing off time, so a little bit of a longer run, so extending sort of the duration of action of the carbidopa-levodopa. We've talked about this before. Contraindicated with citric acid cycle. Contraindicated with tricyclic antidepressants, SSRIs, and other serotonergic agents because of the possibility of hypertensive crisis, serotonin syndrome. And then in addition, some side effects: insomnia, dyskinesias, nauseas, headache, cardiac arrhythmias. But as always, got to know the hypertensive crisis that could occur from MAOIs, tyramine, and other serotonin-like agents. Now we move on to the COMT inhibitors, tolcapone and entacapone. So tolcapone was our central and peripheral inhibitor of the COMT, whereas entacapone is our only peripheral. So as we talked about, this is another enzyme that metabolizes dopamine, and by inhibiting its actions, we can increase the amount of dopamine. So sort of used as an adjunct afterwards, after carbidopa and levodopa has been administered. It can help for freezing and some dyskinesias. It allows you to lower the dopamine dose, L-dopa dose, and it again can attenuate weaning off time. So as we talked about with MAOIs, it can provide you with a chance to lower the dopamine dose and extend the duration of action of the drug, so you're not dosing it as often and you're not experiencing weaning off. Last but not least, just to touch on it, you talked about this a lot in neuroscience first year, but there is deep brain stimulation. It's very invasive, last line. It can improve the patient's tremor, rigidity, and bradykinesia. And if you're using these stimulators, you're able to reduce your L-dopa dose, and their effects last for about 1 to 3 years. This is just an FYI old slide about some of MAOI inhibitors. And then I believe there were a few other agents that were talked about in the lecture. For Tourette syndrome, you can use our typical antipsychotics like haloperidol, which is very useful, but haloperidol has quite a bit of side effects. You can also use clonidine, an alpha-2 agonist, which is our transdermal patch that can cause rebound hypertension. For ALS, you can use baclofen because of muscle spasticity. So baclofen is a GABA-B agonist, and side effects include withdrawal, abuse, and overdose. And then you can use also riluzole, which actually decreases glutamate exotoxicity. So pretty much in ALS, glutamate becomes neurotoxic, and nerves, they believe they're part of the pathophysiology is that nerves are dying because of the glutamate. So this decreases its ability to kill the nerves, and it has been found to delay the onset of ventilator dependence. So big question. Drugs for ALS, well, baclofen is listed here. The only true drug that's been used to treat ALS is riluzole, and it can delay the onset of ventilator dependence, and that's important to know. For benign essential tremor, primidone. If you see benign essential tremor, just pick primidone. And not on the test, beta blockers are also used, but they like to just they like to test primidone as the treatment for benign essential tremor. All right, and I talked a little bit about antipsychotics, so we just have some of the information for typical antipsychotics for your information. And finally, Parkinson's disease. Now, you clearly don't have to know this chart, but this comes from a pharmacotherapy textbook that sort of goes through, if you're diagnosed, what the next step in drug therapy would be. So for a new diagnosis, you do want to start out with an MAOI or a dopamine 2 agonist. If for whatever reason you can catch it very, very early on, and they're very, very literally not very symptomatic, you can use Amantadine. Obviously, we've talked gold standard, carbidopa, levodopa. And after that time, when you've been on carbidopa, levodopa for it, however many years it takes, and you develop dyskinesia, then we want to start thinking about MAOI inhibitors and COMT inhibitors, and then, of course, deep brain stimulation.